and it reduces quality of life in multiple areas. It's characterized by intrusive thoughts, nightmares, and flashbacks of past traumatic events, avoidance of reminders of trauma, hypervigilance or hyperarousal, and sleep disturbances. And it's actually fairly prevalent, with about 3 to 4% of the world's population suffering from this condition. As far as treatment options, it's treated with psychotherapy and daily antidepressants, but often these treatment options leave many patients with insufficient relief of their suffering. About 40 to 60% of patients don't respond to medications, and therapy costs and dropout rates are quite high. The specific antidepressants that are used, most people are familiar with the selective serotonin reuptake inhibitors, so SSRIs. You'll see sertraline, also known as Zoloft, and paroxetine, also known as Paxil, are listed on the slide. That's because they're the only two FDA-approved SSRIs for PTSD, but other meds from the SSRI class and other antidepressant classes are used. Next, what is MDMA-assisted psychotherapy? So in the top left, we see an MDMA molecule. Some people might know it as ecstasy or Molly. And essentially what MDMA-assisted psychotherapy is the combination of MDMA with therapy intended to enhance the benefits of therapy. And so this is currently being studied as a possible treatment of PTSD. So we see a rough overview of what this intervention entails. It starts off with 3 preparatory sessions between the patient and 2 mental health conditions to discuss the patient's psychiatric history, establish a therapeutic alliance between the patient and the guides, and prepare the patient for the MDMA sessions by discussing the possible effects and setting therapeutic intentions. Then comes an MDMA dosing session, followed by 3 integration sessions. So one after the first day of the MDMA session, and then the 2 others within a 4-week period. And that cycle itself is repeated 2 more times. So you get a total of 3 MDMA sessions and 9 integration sessions. Whoops, slid ahead there. As far as dosing goes, in the first MDMA dosing session, it's 80 milligrams followed by a supplemental half dose of 40 milligrams, 1.5 to 2.5 hours after the first dose. And the second and third sessions are 120 milligrams of MDMA followed by a supplemental half dose of 60 milligrams within that same time interval. So that's a rough overview of what MDMA therapy is. At the bottom is just like a progress bar I put together of the steps required to gaining drug approval from someone like Health Canada or the FDA in the States. So phase 1 trials are the first in human trials and are done with healthy volunteers to establish that the drug is safe for human use. Sorry if this keeps happening. Phase 2 studies are slightly larger and are trying to answer questions about dosing and establishing safety in the patient population of interest. So in this case, PTSD. And then there's phase 3 studies, which are even larger trials that aim to establish that a medication is safe and effective in that target population. So right now, MDMA-assisted psychotherapy is in the middle of this phase 3 stage where typically you need at least 2 phase 3 trials for approval. So MAPS has completed their first phase 3 trial known as MAP1, and we'll be talking about that a bit later. And their second one, MAP2, is still ongoing. Estimated approval is sometime around 2023, at least in the States, barring no more COVID-related delays. And approval in other jurisdictions like Canada, Israel would come next, and then subsequently Europe. So now to go over how reuptake inhibitor antidepressants work. This is just a generic picture of two neurons, the synapse space between them. And so in theory, these neurons could be serotonin neurons, where these little red dots are serotonin, or dopamine neurons, where they're dopamine. But essentially what happens is the neurotransmitter gets released from the presynaptic neuron, travels across to the postsynaptic neuron and activates a postsynaptic receptor. That neurotransmitter can get reabsorbed back into the presynaptic neuron by what's called a reuptake transporter. So if this was a serotonin neuron, that reuptake transporter would be called the SERT, or the serotonin reuptake transporter. And if it's a norepinephrine neuron, it's the NET, and so on with dopamine and other neurotransmitters. And so how conventional antidepressants work, at least from a binding standpoint, is they block the reuptake transporter and essentially increase the concentration of the monoamine, so serotonin or norepinephrine or dopamine, in the synapse, and it leads to increased signaling. And then there's a lot of downstream effects that aren't exactly clear, but that's the basic idea behind how these antidepressants work. And so there's different classes depending on their focus. So you have the SSRIs. They're called selective serotonin reuptake inhibitors because they focus more on serotonin neurons and SERT as opposed to NET and DAT. And then you have another class, SNRIs. So this acts on both SERT and NET, acting both on serotonin and norepinephrine. And lastly, there's the DNRIs, or the dopamine norepinephrine reuptake inhibitors. And this is a figure that neatly explains how MDMA works. The figure focuses specifically on serotonin neurons because that's the main neurotransmitter responsible for the observed physiological and psychological effects of MDMA. But it's important to know MDMA acts on other neurotransmitter systems like dopamine and norepinephrine to a lesser extent. So the process I'm about to explain does happen in those other neurotransmitter systems, but again, to a lesser extent. So it starts with MDMA entering the presynaptic neuron through the SERT. It uses it as an entry point, and it interferes with this protein called VMAT, which is responsible for storing serotonin in the presynaptic vesicles. And it leads to the accumulation of serotonin. And really the main effect of MDMA is its ability to reverse the direction of the reuptake transporter. So it actually reverses the direction of SERT and pushes more serotonin out of the neuron into the synapse and prevents its reuptake. And with that increasing concentration of serotonin, you get additional serotonin signaling. So overall, MDMA potently increases serotonin, norepinephrine, dopamine concentrations by reversing the flow of their reuptake transporters. Not pictured in this graphic, but MDMA also weakly blocks SERT, NET, and DAT. So as opposed to reversing their transport, it just blocks other things from getting through or binding. And MDMA also binds to postsynaptic receptors. So something like the 5-HT2A receptor, which some people may know as the one responsible for psychedelics' unique effects. And so that's MDMA's binding there is thought to play at least a small part in its behavioral effects. The point being for these last two slides discussing the shared pharmacology is that MDMA and these reuptake inhibitor antidepressants have overlapping mechanisms, which is the theoretical basis for drug interactions. And if MDMA-assisted therapy is to be approved, it and antidepressants may soon assume competitive positions as treatment options for PTSD. So it's important to understand how to manage transitioning patients from antidepressants to MDMA-assisted therapy or vice versa. And that'll be clinically important for optimal safety and efficacy of the given treatment. So here's an overview of the body of evidence as far as interactions between reuptake inhibitor antidepressants and MDMA. Over the past 20 years or so, various research teams have conducted human drug interaction studies to try and gain a better understanding of how MDMA works, how it's metabolized. So on the left, you can see a column of the interacting drugs that were looked at. So if you take a look at paroxetine, for example, which we discussed earlier, it's an SSRI, and it was given 20 milligrams daily, once daily for 3 days, followed by MDMA 100 milligrams. And that's the general protocol that these studies all took. And all these studies are interesting in their own right, but the important trend to take away from all this is that MDMA's subjective effects were decreased, possibly including those of therapeutic value. And this specifically occurred with SSRI or SNRI interacting drugs. So you can see that bupropion, the dopamine norepinephrine reuptake inhibitor, actually prolonged and enhanced the subjective effects of MDMA. So it's a bit of an outlier. And I didn't mention this earlier, but with MDMA administration, you expect increases in blood pressure, heart rate, and body temperature. But in these interaction studies, it was found that most of these measures did not increase as much as expected when they were interacting with those drugs. So some important limitations about these studies: they were conducted in healthy volunteers and only involved 1 to 11 days of antidepressant use. So their clinical relevance is pretty limited, since antidepressants are taken for much longer periods of time typically. And as we'll see, long-term antidepressant use comes with its own series of changes, neural changes that is, including a decrease in SERT availability and function, as well as reduced serotonin receptor expression and function. So you see how these long-term changes might also interfere with MDMA's mechanism of action, even if the antidepressant is not being taken at the same time. When antidepressants are abruptly stopped, it can result in something called a discontinuation syndrome. It's characterized by symptoms similar to anxiety or depression, with other distinct symptoms, including dizziness, nausea, and shock-like sensations. The figure on the right has a larger list of possible withdrawal symptoms that are experienced, and it's quite an extensive list. Presumably, this syndrome results from a readjustment of the central nervous system to compensate for the removal of the reuptake inhibitor after long-term use. The syndrome can be distinguished from the actual underlying disease that was being treated before by the quickness of onset of the syndrome. So it appears in days rather than weeks, and the rapid response to the reintroduction of an antidepressant. So as opposed to waiting a couple of weeks for a therapeutic effect from an antidepressant standpoint, it just takes hours to days for your body to readjust to taking the antidepressant again. And so tapering is recommended to avoid these withdrawal symptoms, with longer periods on the order of months, resulting in reduced frequency and severity of withdrawal symptoms, compared to something like abrupt discontinuation or shorter tapers, say in the 2 to 4 week range. Ultimately, in practice, the approach to tapering is more of an art than a science at this point, and it's something that you should work closely with the patient together on. The incidence of the syndrome can vary. The averages are around 50%, and the severity is influenced by the drug properties, such as its half-life and receptor affinities, the treatment duration and dose, individual patient characteristics, and the method of tapering. And it can also last a variable amount of time, which is an important consideration once I get to the interactions with MDMA. So it's previously suggested that the syndrome lasts 1 to 2 weeks, but some studies have found that it lasts on the order of months, with some case reports identifying symptoms lasting longer than a year. And so limited drug interaction evidence actually exists with prolonged reuptake inhibitor use. The one study is in mice, and it found that daily citalopram, which is an SSRI, daily administration for 22 days straight significantly altered the effect of MDMA on fear memory extinction in mice. So preclinical research suggests that MDMA enhances the extinction of fear memory as a possible therapeutic mechanism. And fear memory extinction is a translational model for MDMA's therapeutic effects. And so, as I said, 22 days, which is not exactly the length of an antidepressant trial, but it's still significantly longer than the human studies had. It seemed to attenuate MDMA's effects as well. And to revisit this slide, so due to the observed blunted response in both animal and human studies, participants involved in phase 2 trials evaluating MDMA-assisted psychotherapy were required to taper off any psychiatric meds prior to MDMA administration. So the protocols specified for medications to be tapered gradually over a period of weeks to minimize withdrawal symptoms, and for them to be discontinued at least 5 half-lives of each drug plus 1 additional week prior to MDMA administration. Half-lives, for those who don't know, refers to the amount of time that the concentration of the drug decreases by half in the body. And so typically after 5 half-lives or so, the drug is completely gone from your body. And so that tapering takes place after or during 2 preparatory sessions. And that's why there's no time specification for this first segment here, because it takes a variable amount of time depending on the length of the taper. And so now we get to the phase 2 analysis. This was recently published in Psychopharmacology, and it just sought to understand the relationship between reuptake inhibitors and MDMA treatment. So a little bit more about that. Researchers pooled data from phase 2 studies and compared PTSD and depression symptom severity, as well as vital signs during MDMA sessions, between a taper group and a non-taper group. So the taper group, which had 16 participants, were required to discontinue their medications prior to the study start, versus a non-taper group, which was 34 participants who were not taking reuptake inhibitors at the time of this at the time of study screening or enrollment. And the analysis included 4 phase 2 trials, 4 of the 6 that MAPS had conducted, because they wanted to include both measures of PTSD and depression. So the clinician administered PTSD scale, or the CAPS-4 scale, and the Beck Depression Inventory Scale for depression. So 2 of those 6 trials did not include the Beck Depression Inventory, and so were excluded. And all the participants that were included in this analysis needed to have been randomized to the active blinded MDMA group, not any of the placebo groups. And some of these phase 2 trials only used 2 sessions instead of 3. So they just said at least 2, possibly 3 MDMA dosing sessions. And the dosing followed a similar concept where it was an initial dose followed by a supplemental half dose. So the population that was included, it was a chronic PTSD population, so their symptoms have been around for greater than 6 months. A fairly even split of males to females. we know that the average number of days from when medications were stopped to the first MDMA session was about an average of 25 days with a range from 40 to 70. But the length of the taper itself was not known. So there's an important distinction between the length of the taper and the length of abstinence. And lastly, as with most psychedelic research at this point, the analysis lacked racial diversity. So it was mostly white participants. And that obviously has ramifications for generalizing results to a wider patient population that isn't white. Now the results. So the analysis revealed that 1 to 2 months, depending on the study, after the second MDMA dose, the average reduction in the CAP score was 22.6 in the taper group and 41.1 in the non-taper group. So this shows that previous antidepressant use, as you might have expected, affects MDMA therapy because the non-taper group, because they didn't have SSRI exposure, was able to get a much larger decrease in their measure of PTSD, meaning their condition improved significantly. More participants in the taper group still met PTSD criteria compared to the non-taper group. So about 75% of the taper groups was still considered to have PTSD, while only 36% met PTSD criteria in the non-taper group, despite having similar CAPS scores at baseline, meaning that their severity was assumed to be similar at baseline. We also saw a reduced efficacy in decreasing depression symptom severity. So similar to the PTSD effect, the non-taper group had a significantly larger reduction in their depression scores versus the taper group. And in line with the previously observed results from those acute drug interaction studies, increases in peak systolic and diastolic blood pressure during MDMA administration were significantly reduced in the taper group. So in this odd way, it almost had this cardioprotective effect from MDMA. Not that the blood pressures in the non-taper group are that high, but anyway, blood pressure is always a point of consideration from a safety standpoint with MDMA. But interestingly, we didn't see that same impact on heart rate or body temperature. So in those previous acute studies, we saw that SSRI or NRI use impacted heart rate and body temperature as well by increasing them. But the taper group didn't experience any decreases in those measures, as you might expect, and as we saw with blood pressure. So here's a complete list of the tapered medications that were included in this analysis. And so you see it includes tapered reuptake inhibitors, as well as other tapered medications from other drug classes that may or may not be related to the treatment of PTSD. So you see there's anxiolytics, which is anxiety medication. You can imagine that that helps to relieve some of PTSD symptoms. Psychostimulants to help with any drowsiness or alertness. And so the point of this slide really is that 6 out of the 16 in the taper group were actually taking bupropion, which, if you remember, was the exception to the rule in those drug interaction studies. So it's a dopamine and norepinephrine reuptake inhibitor, meaning it doesn't act on serotonin as much. And in that drug interaction study, it actually enhanced the positive mood effects of MDMA. So it's feasible to suspect that if bupropion was excluded from this analysis, the reduced efficacy in the taper group might have been even more substantial if bupropion wasn't included. And at this point, you get the sense that the evidence is pointing towards some sort of interaction where reuptake inhibitors interfere with MDMA therapy. As far as mechanisms and limitations, the authors speculated that MDMA binding sites, so primarily SERT, but NET and DAT as well, may have still been downregulated in the taper group during MDMA administration, which would have prevented MDMA from binding sufficiently and leading to that blunted therapeutic response. In my eyes, that's the most likely mechanism, but the authors also suggested a plausible mechanism of a reduction in the 5-HT1A mediated release of oxytocin. So oxytocin is this other neurotransmitter, and increased oxytocin may partially mediate the prosocial effects of MDMA and the processing of negative emotional stimuli, but its involvement in the therapeutic effects observed in MDMA-assisted therapy is up for debate. And they also raised the possibility that based on the number of medications that the taper group was on when the trial started, that they may have actually had a more severe form of PTSD that was just not captured in their baseline CAP scores. Ultimately, the minimal period of abstinence, so the average of 25 days that was discussed, may not have been sufficient for neurotransmitter systems to return to normal. Now, as far as limitations to the analyses go, it's quite a small sample, only 16 people. And the fact that it was uneven group sizes, 16 in the taper group versus 34 in the non-taper group. So it makes it complicated to draw any real conclusions, and these results would need to be replicated with larger numbers to be confirmed and to help discern what factors affect treatment response among the participants that are required to taper off medications. The variable number of medications and the types of drug classes in the taper group also make it hard to come up with any conclusions. So, for example, there were a greater number of individuals in the taper group that were discontinuing anxiety meds or psychostimulants, and this may have elicited negative effects during the MDMA sessions themselves. And as I mentioned earlier, while the length of the abstinence before MDMA administration was known, the length of the taper itself was not. And that's just important with the idea that the length of the taper has impact on the discontinuation syndrome severity and incidence. So it all seemed pretty clearly pointing towards an interaction between these reuptake antidepressants and MDMA. But then 10 days ago, things kind of changed. So what happened was MAPS published their first phase 3 trial, which is a huge accomplishment for them as far as drug development goes and for psychedelic science in general. This is the first phase 3 trial assessing any of their medical potential. And I won't go into too much detail since I imagine a future journal club will probably cover this paper given the significance. But in short, MDMA was shown to be safe and effective compared with the placebo. You see on this graphic here, the lightest red color indicates responders to treatment. So that entails clinically significant improvement in their condition. And then the darkest red is remission. So essentially the loss of diagnosis, which is an ideal treatment outcome for any medical condition, but it's often hard to achieve. And so really what I'm trying to highlight here is that by the end of the 3 MDMA sessions in the MDMA group, 80% of that group were responders compared to only 50% in the placebo group. And even more astounding was that 30% of the MDMA group were in remission compared to only about 5% in the placebo group. So those are just high-level results. It was also very well tolerated and just kind of built on the already established safety of MDMA when given in this specific treatment context with the support and the medical screening beforehand. And they did an analysis on the impact of SSRIs on the effectiveness of MDMA in this trial. And what you see highlighted is the results of that subgroup analysis, but it essentially says there was no obvious impact of SSRI history on the effectiveness of MDMA, which was quite surprising when I first read about it. And so what do we know from this trial? Well, the information given related to previous medication history and this larger subject of the interaction between SSRIs and MDMA wasn't that well fleshed out in the publication of the phase 3 trial. That was more focused on the safety and efficacy results. But what was revealed was that over 65% of participants had a lifetime history of SSRI use. So that doesn't necessarily mean they were taking an antidepressant right before the trial start, but a fair proportion of the population clearly had exposure to these therapies, and that the taper length before any MDMA administration varied from 0 to 103 days. So 0 presumably meaning patients who were not on anything, up to 103 days, which is quite a long time. But again, the slower the taper, the more optimal outcomes as far as avoiding that discontinuation syndrome. But no average taper length was provided. So that's problematic. On the right, you see a table of the proportion of patients who were taking either sertraline or paroxetine. So if you remember, those are two SSRIs that are specifically FDA approved to treat PTSD, whereas other drugs in the class don't have that specific approval, even though they are off-label. So only those two drugs were reported as pre-study PTSD medications. We didn't find out whether other SSRIs or SNRIs were being used right before this trial start, or even drugs from other classes like anxiety meds or psychostimulants. And you could see it's still a fairly small actual number. So only 11 out of the 46 in the MDMA group were listed as taking either sertraline or paroxetine. And we know very little about the analysis itself. So it wasn't well described or had its own dedicated publication like this phase 2 analysis. So we don't know whether other SSRIs or other reuptake inhibitors were included in the actual analysis. So what does this all mean? Well, it's frankly unclear, given the small samples that have been used, with 16 in the phase 2 analysis and only 11 participants in this phase 3 trial. So again, it's hard to draw any definitive conclusions about what's happening here. I personally think that there's still a possibility of an interaction, but that it's likely dependent on the type of antidepressant, the treatment duration and dose, individual patient characteristics, the length and method of the taper, and the length of abstinence period before MDMA administration. Excuse me. And so moving forward, MAPS has discussed the possibility of conducting a safety study where patients who are currently taking a reuptake inhibitor are given a higher dose of MDMA at the same time to see if this sort of blunted response can be overcome by a higher MDMA dose. In the meantime, we're likely going to have to wait for a reanalysis of more data after the completion of MAP2, the second phase 3 trial, which is currently ongoing. Ultimately, I think this is an important area for identifying a source for decreased MDMA efficacy, but it also just generally raises questions about the future management of patients with PTSD and how to optimize the effectiveness of their treatment. So the most prominent questions in my eyes are along the lines of how long an abstinence period is required to avoid this reduced efficacy, if there is any, and is that length of time without an antidepressant safe or reasonable for patients who are clearly struggling with PTSD. And so, as with most drugs, we'll learn a lot more about it after it's approved and gets delivered to a wider patient population. And so I just want to give a quick shout out to the Psychedelic Pharmacists Association, which is a nonprofit that I co-founded with some pharmacy colleagues with the intention to help educate pharmacists about psychedelics even before their approval, just to be able to serve their community as a resource for accurate drug information. And we're already seeing, given the increasing media coverage of psychedelics, that people are self-medicating more often with them. So just to serve as a harm reduction resource. The association is also intended to provide networking opportunities and lastly, to advocate for the greater pharmacist involvement in the delivery of psychedelic care if and when it receives regulatory approval. The subject that I've been discussing as far as medication tapering and medication management overall is what pharmacists are experts in, and I believe can help mitigate the risks of psychedelics and optimize their efficacy. So those are the references, and that's it for my presentation. I'm happy to take any questions you have, and there are links to the association in case you are interested in signing up on our interest form, and the drug development tracker that is hosted on Psilocybin Alpha, in case you're interested in trying to keep up with all the different companies in the psychedelic space and all the different psychedelic molecules they're looking at and where they are in the drug development process. Thanks.
Great. Thank you so much, Michael. That was a great presentation, and we really appreciate you being able to modify it a little bit to go into a bit more depth, since Nadia unfortunately couldn't join us today. So just a reminder, you can drop your questions into the chat. If you would like to speak your question, just use the raise your hand function and we can unmute you. The first one here is from Danica, and they ask, is MDMA's action on CERT similar to Adderall's action on DAT?
Adderall's action on DAT, yeah, it's similar. I mean, they're both amphetamine derivatives, which as a class, they generally have the property of reversing the flow of the reuptake inhibitor. So Adderall does that for dopamine more specifically, although it does to a lesser extent with norepinephrine and serotonin, whereas MDMA preferentially does it for CERT as opposed to DAT and NET. I hope that answers your question, Danica.
Thanks. Next question here is from Gus. And they go, I'm tapering off Prozac after 2 years. I want to start psilocybin microdosing. I've heard that I can start microdosing after 3 weeks when I stop Prozac with 50 to 100 milligrams of psilocybin. What do you think of the Fadiman protocol to start microdosing?
So fluoxetine is unique among the SSRI class in that its half-life is really long. So it requires a much longer discontinuation or taper period. I should also say this is not medical advice. If you do want to discuss this more at length, you can reach out to me in private. But like I said, fluoxetine requires a much longer taper period than the other antidepressants. So 3 weeks does not seem to be enough. That being said, getting into the effectiveness of microdosing is a whole other conversation. I was hoping to hear from Nadia about that tonight, but whether it would interact, that's still unclear. Also, the relationship between psilocybin and these reuptake inhibitors is less clear than MDMA. Although, if I had to guess, it's probably a similar relationship. And as far as the Fadiman protocol, I mean, I can't speak to it any better. I did see, I think, one of the researchers from U of T's microdosing center in the chat if they want to comment on the protocol, but I believe that's the one where you take you dose on one day and then break for 2 to 3. Someone can correct me if I'm wrong.
Thank you. And we'll definitely let everyone know when Nadia is able to reschedule for sure, because I know lots of people were looking forward to that as well. Next question here is from Leo. Economically speaking, do you think it's possible for MDMA to displace current treatments? Would accessibility be comparable?
That's the $1 million question in psychedelics right now, is whether they can be scaled adequately. So to keep this in perspective, MDMA-assisted psychotherapy involves 2 mental health clinicians and a lot of therapy hours. Therapy has not been traditionally covered extensively by insurance in North America, or really the world. So that's always going to be a challenge, simply based on the availability of therapists, added to the fact that therapists require specialized training to deliver this MDMA-assisted therapy. So it'll be even less accessible until more therapists are trained. And then showing that the therapy is cost effective. So that's part of what MAPS is working on now with phase 3 studies, is kind of tracking health economic outcomes to assess the cost effectiveness. And then there's this whole process of submitting to the payers and trying to argue that it is more cost effective than standard care. So I'm skeptical. It's going to take a lot of time and work to prove to these insurance companies to reimburse such an expensive therapy. But if it is shown to be cost effective, which it has been with phase 2 trials, but those have to be taken with a grain of salt, that it may displace current treatments, but ultimately that's dependent on insurance coverage and the establishment of cost effectiveness. So sorry, that was a roundabout way of answering it, but it's a maybe and a product of time too. So having these ongoing negotiations and assessments of its cost effectiveness after it's approved.
And I think Brian's question builds off of that quite nicely. And they ask, do you believe MDMA also has potential to treat anxiety or depression on lower doses? And is this something you believe will be accessible soon via providers?
That's a tough question, because in the phase 2 MDMA studies, the comparator group, instead of a placebo, was what's called an active placebo, where they used low dose MDMA to be able to tell participants, everyone's receiving MDMA to minimize expectations. But what they found was that the low dose MDMA actually worsened people's PTSD symptoms. So the idea of low doses of MDMA being able to treat anxiety or depression, that hasn't been studied at the moment, but just inferring based on those phase 2 results, I'm not sure it would actually help, and it might even make things worse, just in terms of, bringing up bad memories or making people uncomfortable dealing with the emotional experience that comes with MDMA. And as accessible via providers, like I said earlier, MDMA therapy is only going to be approved at the earliest in 2023 in the States. And even then, we'll have pretty strict regulations surrounding how it's provided. So under supervision by clinicians in this thorough screening process. So accessible soon via providers, definitely not in the same way that, you know, people are familiar with getting a prescription from a prescriber currently.
Thank you for that. Next question here from Zena. Does MDMA bind to the 5-HT2A receptors to the same extent or in a similar manner as classic psychedelics?
In the same extent, in the same manner. I mean, it does bind to it. The main difference between those classic psychedelics is that MDMA's kind of subjective effects are largely mediated by its action on the reuptake transporters, specifically SERT and NET. But I believe there's some animal research where they blocked the 2A receptor, and that somewhat reduced the subjective effects of MDMA. So it does play a role, but definitely not to the same extent. And as far as the binding specifics, I can't comment on that.
Thank you. Next question here from Renzo. Does the topic of serotonin syndrome come up in MDMA therapy, or is it more theoretical?
So in the larger topic of MDMA therapy, it's definitely a concern always. So for those who aren't aware, serotonin syndrome is this super rare but pretty serious and severe reaction when there's basically excessive serotonin signaling. And it happens when you combine drugs that both act on the serotonin system to increase serotonin signaling. Some people might think that drugs like SSRIs, since they do increase serotonin when combined with MDMA, those two might cause serotonin syndrome together. But as we saw with the drug interaction studies, the reuptake inhibitors actually prevent MDMA from working. And that's thought because the reuptake inhibitor prevents MDMA from entering the presynaptic neuron and actually working. So the serotonin syndrome risk between these reuptake inhibitors is either low or non-existent, but there's certainly a cause for concern with other drug classes. So older antidepressants like monoamine oxidase inhibitors definitely have that serotonin syndrome risk. And it's worth discussing with a healthcare provider if you're on certain medications, because that risk is still there and worth being cognizant of.
Thank you. Stephanie has the next question here. They say, thank you, very interesting presentation. Do you have any data or knowledge of participants in the MDMA trials who ended up going back on their medications following their involvement in the trials?
Yeah, so for the phase 3 stuff, it's still too early for these long-term follow-ups. For the phase 2 trials, there were some long-term follow-ups done that extended out to a couple of years. And although it showed increasing or at least sustained efficacy out to a long time period, there are certainly cases of patients in the active MDMA groups that, you know, had either didn't respond in the first place or had a disease relapse. So it certainly happens. Another part of this is that within these strict clinical trial settings, you're limited to the number of integration sessions you get. So you hear anecdotal reports of MDMA patients who feel there was some improvement, but didn't find that there was enough therapy after the fact. And so once the trial ended, they felt a little abandoned and often sought like underground help from underground psychedelic therapists. But no drug works perfectly, and so there's definitely participants who ended up going back on their medications or sought therapy again. These are not a miracle drug, but they do seem to work better than what we have so far. So that's where the excitement lies.
Thank you. And then just last kind of question / comment here from Kelly, and perhaps if you can connect privately after as well. But they say, thanks, great presentation. I'm wondering if you've promoted your pharmacist group with the Canadian Psychedelic Association. And then they just said that they're a member, so they can help connect if you have not yet.
Thanks, Kelly. Yeah, we should definitely touch base offline. I believe I've brought it up with some folks from CPA. But it's worthwhile re-exploring. That is something I should get on.
Perfect. Well, thank you again, Michael. We really appreciate you sharing all your expertise and knowledge with us. And thanks to our audience for sending in some great questions. I will pass it back to Leo now to close us out.
All right, thank you guys, everyone. Just for some housekeeping, our next meeting will be June 17th, and this will be back at our normal time of 8 p.m. Eastern time. So hopefully we'll have a little bit more people from BC joining us then. Our speakers will be Manoj, it's supposed to be DOS. It's on the effects of salvatorin A, or salvia, on functional connectivity, and Jay Olson, who will be talking about tripping on nothing, placebo, psychedelics, and contextual factors. So stay tuned and sign up for our mailing list to be kept up to date with these talks. And I sent the link in the chat, so you can follow that to give us any feedback or any other questions as well. Thank you guys so much for joining us today, and hopefully we see you guys next month. Take care. Bye-bye.